reflux disease. It's self-explanatory. Terminologies in medicine are self-explanatory, so we are blessed. That's how we name diseases. Okay, so gastroesophageal reflux disease means gastric acid gets refluxed into esophagus. It's getting back into esophagus. It's an irritation. It's a stress for the squamous epithelial lining. So because of which it gets replaced by this columnar or glandular epithelium. So what's the problem with glandular epithelium? It's long-standing. Yes, it can become cancer, it can become adenocarcinoma, which is long-standing. So you have to treat this GERD or gastroesophageal reflux disease. Your patient will come with burning sensation in the chest and dyspepsia and belching and all those things. And when you do esophagoscopic examination and take a biopsy, you will see this glandular metaplasia. It is called Barrett's esophagus, named after the discoverer. Okay, please remember very, very high fact. Barrett's esophagus is seen in GERD and it is precancerous. You have to treat GERD, otherwise it becomes a adenocarcinoma later on. Similarly, there is another condition called intestine metaplasia of gastric epithelium. So whenever there is H. pylori infection, again this you will learn in your classes on GIT in path 2, you will see that when there is H. pylori infection of gastric epithelium, there can be metaplasia. The gastric glands get replaced by intestinal glands. And you will start seeing goblet cells and Paneth cells, which is normally absent in gastric epithelium. You see goblet cells and Paneth cells in intestine, but you will start seeing it in gastric epithelium. That's metaplasia, intestinal metaplasia. So metaplasia need not always occur in epithelial cells. It can also be seen in mesenchymal cells. Best example is myositis ossificans. What do you mean by myositis ossificans? Myo means, yes please?
Isn't it growth of bone inside of skeletal muscle?
Yes, exactly. So you will start seeing bone start growing in a muscle, skeletal muscle. That's called myositis ossificans. It's a wrong term actually. It's not itis. It should not be itis. Itis means inflammation. It's not an inflammatory condition, but still they continue using this term. Myositis ossificans. That means you're seeing ossification of skeletal muscle. Usually, you encounter these in some blunt trauma, blunt injury, where there is some trauma to skeletal muscle fibers. If there is some traction and some shearing forces, because of which the muscle cell gets disturbed and the stem cell starts getting dedifferentiated into bone cells, osteoblasts, and they start depositing osteoid, and later on you will start seeing bone formation. And when you take an X-ray, you can find these opacities. Similarly, even cartilage or adipose tissue can be seen in these elements, in these metaplasia. Myeloid metaplasia already discussed. So if you see hemopoietic tissue in spleen or liver, that means it is myeloid metaplasia. It's also called extramedullary hematopoiesis. Medullary means bone marrow, so extramedullary means out of bone marrow hematopoiesis. This is Barrett's esophagus. This is the lower one-third of esophagus. You can see here this is squamous epithelium, which is getting replaced by glandular epithelium, columnar epithelium, which is growing here. This is myositis ossificans. You are seeing bone osteoid in the skeletal muscle. Now the next entity is dysplasia. It's not a true adaptation, but still it's worthwhile to discuss at this point of time because we have discussed most of the adaptations, and even dysplasia is reversible in that sense, so you can take it as one of adaptations. So it's atypical hyperplasia or atypical metaplasia with potential for evolving into cancer. What do you mean by dysplasia? That means there is some atypia. Atypia means there is loss of organization. What happens is there is change in the size and the shape of cells. There is loss of organization of cells, loss of polarity, and increased mitotic activity. When you see these three changes in an epithelium, we call it atypia. Okay, so atypia can be seen in association with either hyperplasia or metaplasia. So when it shows atypia, that means the cells are arranged haphazardly in architecture. Like they lose polarity and they lose maturation, and you see a lot of mitosis, and you will see one cell is large, one cell is small, one cell is small, medium size, something like that. Then that means there is some loss of architecture or orientation. That means it is ATPR. But if you leave it as it is, it can become cancer. Dysplasia is reversible. I mean, if you treat this condition, it goes back to its normal state. But if you leave as it is, then it becomes cancer. So dysplasia is a link between hyperplasia and cancer. So just like squamous metaplasia, similarly, it's a link between metaplasia and a cancer. For example, squamous metaplasia of cervix. Okay, cervical squamous metaplasia due to human papillomavirus infection becomes dysplasia and later on becomes cancer. Okay. Similarly, endometrial hyperplasia can become dysplasia, which is still reversible, and later on becomes cancer. So it's a link or continuum. In simple words, dysplasia means disorderly growth. I think if you see these pictures, it will be pretty obvious. This is normal squamous epithelium in cervix, that is uterine cervix. Whereas here you can see here there is loss of maturation because there is here you can see well discrimination between basal cells, intermediate cells, and superficial cells. But here everything are take oval shape and they are haphazardly arranged. You see, long axis of one cell is not parallel to another, and there are a lot of mitotic cells like these mitotic fibers. That means it's dysplastic epithelium. Another example in hyper. You can see there is variation in the size of the nuclei, shape, orientation, architecture, overall dysplasia. But you can see the basement membrane is still intact. They are not cancer cells. They are yet to become cancer cells. They are dysplastic cells or atypical cells. Okay, they are pre-malignant. These terms are very important. Pre-cancerous or pre-malignant. That means if you can treat them, they're not actually cancer, but if you leave it untreated, it can become cancer. That's the meaning of the term pre-malignant or pre-cancerous condition. So dysplasia is pre-malignant. Okay. Causes for dysplasia like hyperplasia. As I told, endometrial hyperplasia becomes endometrial dysplasia. Later on, it becomes endometrial cancer. Similarly, squamous metaplasia of bronchus becomes squamous dysplasia, and the squamous dysplasia becomes squamous cell carcinoma. It's a spectrum. Okay. Similarly, HPV infection causes cervical squamous metaplasia, which becomes squamous dysplasia, which becomes squamous cell cancer later on. Okay. And similarly, solar damage to skin causes squamous dysplasia. This is very, very important. Dysplasia is reversible, but it becomes cancer later on if you don't treat it. I think case studies you can study on your own. So this is renal atrophy. You can see the kidney is shrunken drastically and the thickness of the cortex is reduced or it's thinned out. Renal atrophy. So this is to compare normal kidney. And this is normal bladder epithelium transitional, whereas here it has become squamous here. This is patch of squamous. Because of this schistosoma parasite, you can see the eggs here. Okay, we go to the next problem. Any questions at this point? Any clarifications? Please feel free. I'm glad to receive questions. Okay. So the next stage is if the cell fails to adapt, it will suffer from injury. So next in the spectrum. So initially the cell tries to adapt whenever there is some injurious stimulus, but if it cannot cope up with the stimulus, it suffers from injury, which can again be reversible or irreversible. Okay. So we'll study. So far we studied adaptations. Now we'll study something about cell injury. My special thanks to Dr. Srinivasan for his original PowerPoint, but I have made some modifications. So, you know that cell is in a normal, a normal cell is in a dynamic state of homeostasis. So, they try to adapt. If they fail to adapt, it will suffer from injury. It can be two types, reversible or irreversible. So, there is an injurious agent which can bring about adaptation. And if the cell fails to adapt, it will show reversible injury. And at certain point, the reversible injury becomes irreversible injury. That means even if you remove the injurious stimulus, the cell cannot recover. So eventually it has to die. That is irreversible injury. Later on it dies. Okay. Now, what can cause injury to cell? Let us say a human being. Suppose you want to injure me. In what all ways you can injure? You can hit me, you can strangulate me, what else you can do?
Lack of oxygen.
Sorry?
Lack of O2. Lack of
Oxygen, yes, hypoxia. So that's what you can strangulate me or drown me or something. Yeah, poisons. So toxic substances or viruses or thermal injuries. You can burn me or freeze me. Thermal injuries. And so there are so many ways to injure a human being. Similarly, at a cellular level, the same holds true. A cell can get injured whenever there is inadequate oxygenation, what you call hypoxia. Physical agents like mechanical trauma, burns, radiation, electric shock, chemicals, as I said, poisons, infectious agents. I'll not read the slide, I'm not a news reader. You read it on your own. Okay? Something to explain, I'll explain. Nutritional imbalances and genetic problems can actually cause or injure cells. Okay. Now, reversible and irreversible cell injury. Okay, I already discussed several times the differences between reversible and irreversible. Now, we'll discuss some examples. Hypoxic cell injury, ischemia reperfusion, free radical induced injury, and chemical injury. We'll discuss in detail, then everything will be very clear for you. Okay. Do you know this person? He must have been introduced to you in some previous semesters. No? He's James Smith.
Oh, I don't know my picture.
Maybe in physiology or anatomy. Histology of myocardium. So what are you noticing here? He's having some problem. He's having acute chest pain. Okay? So he is James Smith. So he is 42-year-old man, married male physician, and he has non-insulin dependent diabetes mellitus, and he has moderate hypertension, and he presents to ER with chief complaint of my chest is hurting. So what's your diagnosis at this point? At least differentials. Angina, yes, that's one of your differentials. Anything else? Chest pain. Myocardial infarction, yes. How do you want to differentiate between angina and myocardial infarction?
EKG.
EKG can show some, EKG can still show some abnormalities in angina too.
Blood test.
Sorry? Serum levels, yes. You have something to say?
I would say the cardiac enzyme method.
Yes, excellent. So in which condition it is increased?
In
Myocardial infarction, but it's not increased in angina. So which is reversible injury and which is irreversible? Angina is reversible. So your patients, the myocardial cells suffer from reversible injury. They recover when the patient takes rest. So this is, and when actually angina is an alert sign for you to foresee myocardial infarction. If you don't treat angina, one bad day it may become myocardial infarction. So your patient, James Smith, had onset of sudden severe substernal chest pain tonight while making rounds at the hospital, and the pain was precipitated by walking a few steps and was relieved somewhat by the rest. So what's the problem in angina? The coronary artery is narrowed, but still the blood supply is somehow adequate. But when the person exercises, like he's taking rounds, when there is an increased demand, then there is some scarcity of blood supply, or then this angina gets precipitated. Okay? So there is narrowing of the coronary artery, and because of which he gets this hypoxic injury to his heart muscles, and he will have anginal pain. And the pain radiates to his left jaw and chin, and he had similar episodes earlier in past 6 months. BP is raised, EKG shows altered electrical rhythm. And lipid profile shows increased cholesterol. That speaks about atherosclerosis. And enzymes are not elevated. CKMB, troponin I, and T are not elevated. That rules out your myocardial infarction. Okay, so now you have diagnosis in your hand. It is angina pectoris. And when you do angiogram, you see 98% blockade of right coronary artery. Okay, that means it is a reversible injury. Okay, the myocardial cells suffer from ischemic or hypoxic injury, which is reversible. And again, the response to injury depends, or injury stimulus depends on the type of stimulus, the duration of stimulus, and severity of the injurious agent. Okay, and it also depends on the adaptability of cells. Like these neurons are very much sensitive for hypoxia. Like even some 3 to 5 minutes of hypoxia can actually cause injury to neurons. Whereas for myocardium, can somehow thrive or can cope with this hypoxic injury for 1 or 2 hours, but not beyond that. Okay, and skeletal muscles can cope still further for several hours. Now let us say there is a stressful stimulus. Which all part of the cell can get injured? We discussed which all agents can actually injure the cell. Now common sense. Which all part of the cell can get injured? So cell has various organelles. It has a nucleus, it has cytoplasm, and it has many organelles. So any of these organelles can get injured and eventually lead to injury to cell, and eventually the cell injury becomes irreversible and eventually to death. So now, which structures can get, or which functions can get hampered? One is production of ATP by aerobic respiration. That gets hampered. That is one of the mechanisms, especially in hypoxic injury. Whenever there is decreased oxygen supply, the first thing that happens is arrest of aerobic respiration. So the cell can now thrive only by anaerobic glycolysis. You know this. Your Krebs citric acid cycle gets shut down, and because of lack of oxygen, but glycolytic pathway in the cytoplasm continues. And what happens? What is the end product of glycolytic pathway? Lactic acid. But it cannot become pyruvic acid, and it cannot enter the Krebs citric acid cycle because there is no oxygen. But still, the cell tries to manage to get ATPs. How many ATPs you get from one molecule of glucose in anaerobic glycolysis? 2. Yes. So somehow the cell gets ATPs even though there is no oxygen. So that is aerobic respiration. Okay. So aerobic respiration gets arrested whenever there is hypoxia. Cell membranes are another site where they can show injurious this is another site where you can notice injury. I think we discussed further slides, everything will be very clear. And when there is decreased ATP synthesis, protein synthesis gets hampered. You know, ATP is required for protein synthesis. Where is protein synthesized? Which organelle?
ER.
Which kind of ER?
RER.
Rough.
Yes. So your ribosomes get arrested, and your rough ER will stop synthesizing proteins. And similarly, there is decreased synthesis of nucleic acids, and damage to one system affects the other. I think we have a flow chart. Let us say there is an injurious stimulus. Let us say hypoxia, most common. There would be decreased ATP synthesis, and you know there are many cellular functions which are dependent on ATP. So whenever there is decreased amount of ATP, all these functions get hampered. And some injurious stimulus can actually cause direct damage to membrane. For example, some toxins can cause damage to membranes. And membrane can be 2 types: the cell membrane or the lysosomal membrane or mitochondrial membrane. So membrane of the organelles or the membrane of the cell as a whole. So what happens if mitochondrial membrane is damaged? There is a molecule called cytochrome C, which is one of the molecules which is involved in electron transfer chain.
Apoptosis.
Yes, if the cytochrome C escapes into cytoplasm, the cell undergoes apoptosis. And if lysosomes get ruptured,
Hydrolytic enzyme.
yes, autolytic enzymes. And if cell membrane gets damaged, there is loss of cellular contents. and there is increase in the concentration of calcium in the cytoplasm whenever there is injury to plasma membrane or membrane of mitochondria or ER. What happens when there is increase in the level of calcium ions in the cytoplasm? They will in turn activate various enzymes, and that can lead to proteolysis or protein breakage. Okay? We will discuss the details later on. We have many more slides to go. We'll cover the details there. And you have something called reactive oxygen species. We'll discuss what these reactive oxygen species are in the next few slides. So basically, there's influx of calcium, ATP depletion, mitochondrial damage, and loss of permeability of cell membranes, and free radicals. And you can remember this mnemonic CAMP R. Now we will discuss some examples like hypoxic cell injury. These are very, very high impact, so please try to concentrate. So what is hypoxia basically? By definition, it's there on the slide.
Decreased oxygen delivered to a tissue.
Excellent. So inadequate oxygenation of tissue is what you call hypoxia. And it is very common cause or the most common cause of cell injury. Okay, so we will discuss hypoxia in detail. And there are different types of hypoxia or major causes of hypoxia. And the most common is ischemia. What is the difference between ischemia and hypoxia?
Ischemia is decreased perfusion or decreased blood supply to the
To the what is hypoxia?
Decrease in O2.
Yes. So what is the difference between the two? Ischemia is if there is a blockade in the blood supply. Of course, the organ will be, the end organ will suffer from hypoxia when there is ischemia. Along with hypoxia, there is decreased supply of nutrition, everything, because total cutoff of blood supply. So there is no supply of nutrition, no oxygen supply, and no clearing of metabolic waste. So this is ischemia. Whereas hypoxemia is inadequate oxygenation. So ischemia is one of the subtypes of hypoxia, or in ischemia you may encounter hypoxia. Now you tell me which is more dangerous, hypoxia or ischemia? Ischemia, common sense, yes. Whereas there's another term called hypoxemia. It's not hypoxia, hypoxemia. What do you mean by hypoxemia? Yes, please.
Decreased dissolved oxygen in the blood.
Yes, in the plasma. Yes, excellent, awesome. So normally when we take in oxygen in our lungs, in the air, the oxygen that's present in the air gets into our lungs, bronchial tree. What happens? The oxygen diffuses across the pulmonary membrane and enters the blood vessel, okay, and enters the plasma. First, it gets dissolved in the plasma, and then it equilibrates with the oxygen that is bound to hemoglobin. So it's in an equilibrium between, the oxygen that is bound to hemoglobin is in equilibrium with the oxygen that is dissolved in plasma. And the amount of oxygen that is present in the plasma is in equilibrium with the amount of oxygen that is present in our alveoli. So that's how first oxygen gets into plasma, gets dissolved in plasma, and then enters the RBCs and binds to hemoglobin. So the hemoglobin, the oxygen that is bound to hemoglobin is different, but the oxygen that is dissolved in plasma is what? If it is decreased, then it is called hypoxemia. That is the amount of oxygen dissolved in plasma. And then there is in which conditions you have hypoxemia? Any defect in either ventilation or perfusion or diffusion causes hypoxemia. That means oxygen is not getting, crossing over from lungs to blood. Okay? So like, if there is defect in ventilation, like atelectasis or collapse of a portion of lung, so what happens? It is getting blood supply, but air is not getting entered, or the air is not entering the alveoli. That means it is what defect? Ventilation or perfusion defect? You tell me. Is it ventilatory defect or
ventilation?
Ventilatory defect. Okay. Or else the second situation is pulmonary embolus. Some solid material gets stuck in the pulmonary vasculature and it's obstructing the pulmonary vasculature, because of which there is good ventilation but no perfusion. It's not perfused by blood because it is obstructed by embolus. So the defect is perfusion, okay, not ventilation. And the third one is diffusion. That is, ventilation is fine, perfusion is fine, but if the uh, alveolar membrane is fibrosed because of interstitial fibrosis, then again the oxygen cannot diffuse from alveoli to blood. Whatever the causes, the person will have hypoxemia. And the third condition is if there is decreased oxygen carrying capacity of blood, like anemia. How do you define anemia? Decreased hemoglobin content. So if the person has decreased amount of hemoglobin, naturally less hemoglobin, less oxygen supply. Right? It could be due to any cause. You have a big chapter on anemia and later blocks you learn about it. Carbon monoxide poisoning. How does carbon monoxide cause hypoxia? Sorry?
Competitive heavy with hemoglobin.
It binds with hemes and it binds and replaces oxygen. So, and once carbon monoxide occupies hemoglobin, it's very difficult for oxygen to replace it. So, how do you treat these conditions? You supply 100% oxygen, and so this oxygen goes and replaces carbon monoxide. Okay? And in which situations you get carbon monoxide poisoning? In which kind of patients will suffer? Yes,
Fires.
yes, people who are trapped in house fires. Yes, and you rescue them, and they would have inhaled these carbon dioxide and carbon monoxide. Another thing is
Attempted
carbon. Yes, that is automobile exhaust is rich in carbon monoxide. So if a person encloses himself in a garage and he starts his car engine, he will die due to carbon monoxide. Anything else? Any other conditions?
Problem with like the boiler system or
Yeah, electric room, not electric, what is it? That room heaters. Wow, what kind of? Sorry? Furnace, yes. These traditional room heaters, so what happens? If there's incomplete combustion of these oxygen, there will be carbon monoxide released. These are some clinical scenarios where your patients can suffer from carbon monoxide. So this we already discussed. So when there is decreased partial pressure of oxygen, that's called partial pressure of oxygen. The oxygen that is dissolved in plasma is called partial pressure of oxygen. When it is decreased, that is called hypoxemia, and the cause could be ventilation or perfusion or diffusion effects. Okay, and defects in oxygen saturation. That's the difference between partial pressure of oxygen and oxygen saturation. When I say oxygen saturation, I am speaking about oxygen that is bound to hemoglobin. And when I say partial pressure of oxygen, I am speaking about oxygen that is dissolved in plasma. Please don't get confused with me. And defects in oxygen saturation, like methemoglobinemia. What do you mean by methemoglobinemia? Yes, yes. Your iron, which is supposed to be there in ferrous state, is in ferric state, and because of which the hemoglobin loses its function of carrying oxygen. Okay. And how do you treat these patients? What medicine? Methylene blue. Awesome. Yes. Anemias.
Methylene.
You will have separate chapter on anemias. And
Methylene.
defects in oxidative phosphorylation. So cyanide poisoning or carbon monoxide. All these substances can bind to cytochrome oxidase and interfere in electron transfer chain, and because of which your patients will have hypoxia. And there are some certain substances called uncouplers. What do you mean by uncouplers? You know where this ATP is synthesized in mitochondria. That's why you call it powerhouse of the cell. And your mitochondria has inner layer and outer layer, and you have this cristae. Okay. So what happens when electron gets transferred? The energy is used in pumping iron from mitochondrial matrix to intermembrane space, that is in between inner and outer mitochondrial membrane. And later on, these hydrogen ions or protons get back into matrix through certain channels, and these channels have these enzyme ATP synthase, and that's how ATP gets, the energy is trapped, and that's how ATP gets synthesized. If you remember this, there are certain toxic substances which can disturb this, and they are called uncouplers. And what do they do? They somehow increase the permeability of this inner mitochondrial membrane, and protons diffuse back into matrix, not through the channels but directly bypassing this ATP synthase. So even though electron is transferred in the ETC, it's not the energy released is not used in synthesis of ATP. So that's uncouplers like alcohol, aspirin, 2,4-dinitrophenol, etc. Okay, similarly, arterial venous shunting. If there is some abnormal connection between artery and veins bypassing the capillary bed, what happens? There is no oxygen supply. Okay, all these leads to hypoxia. Okay, I think it was more elaborate. That's okay. It's worth discussing because you may get questions on these areas. They are very high. Now, once there is hypoxia, let us see what happens in the cell. Now we are studying how a cell gets injured when there is hypoxia. And the cause for hypoxia could be any of those reasons we discussed. Okay. Now once the cell suffers from hypoxia, what all things happen in the cell? We will discuss now. One thing is there is decreased ATP production because of shutting down of oxidative phosphorylation. And you know ATP is required for many functions of cells like membrane transport, protein synthesis, liposynthesis, etc. And because of which all these functions get disturbed, and the cell now tries to synthesize ATP by anaerobic glycolysis, and there is generation of ATP in the absence of oxygen, but the problem is there is building up of lactic acidosis. Okay? Now, let us say ischemia. There is an artery which is blocked. Let us say due to atherosclerosis, later on shows thrombus and there is complete block. What happens when there is ischemia? There is decreased oxidative phosphorylation, decreased ATP synthesis. What happens when ATP synthesis is, or when there is decreased amount of ATP? Very, very high ATP. You know the sodium pump. What does this sodium pump do on the cell membrane?
Sodium out.
It pumps out sodium and takes in potassium. It pushes sodium out and takes in potassium. And it requires ATP, right? Now there is decreased ATP. What happens? Sodium gets accumulated within the cell and potassium escapes. Okay, because this pump is failing. And what happens when sodium accumulates in the cell? It's an osmotically active substance. So water gets trapped in the cell cytoplasm. What happens when water gets trapped in the cytoplasm? The cell swells. Very, very important. Yeah. I mean, in the initial stage, it just swells. Okay, when it bursts, it becomes irreversible. Now we will restrict ourselves to reversible injury. The cell swells. That is the first microscopic feature which you will appreciate under a microscope. When you see a cell which is swollen, then you think, or you have to think that probably the cell suffers from ischemic damage, irreversible ischemic damage, or hypoxic damage, to be precise. So influx of sodium and water and efflux of calcium, cell swells. And if you take the cell under electron microscopy, you will appreciate that all the cellular organelles like mitochondria, endoplasmic reticulum, microvilli, all of them show swelling. Okay.
Swelling.
What happens when there is anaerobic glycolysis going on? The glycogen is exhausted. Okay, the glucose gets exhausted. That is, increased glycolysis leads to decreased glycogen and increased lactic acid. What happens when acid builds up? The pH drops. Okay, when the pH drops, the nuclei chromatin clumps. There is some denaturation of proteins because of increased pH, because of which the chromatin clumps. These are the changes you will appreciate that there is reversible injury due to hypoxia. Okay. Now, what happens when the endoplasmic reticulum swells up? I told you initially it swells up. When it swells up, the ribosomes which are attached on the surface of rough ER gets detached because now it's swollen. Okay, when it gets detached, it cannot form polysomes and protein synthesis is hampered. Okay. Also, there is no ATP, so no proteins, no synthesis of proteins. I think I'll skip this slide because we already discussed. Okay. This also we discussed. Now, when there is hypoxia, the cells show swelling because of accumulation of water. After some time, fat gets accumulated in the cell too. Why should fat get accumulated in the cell when there is hypoxia? Can you guess? Sorry? Sorry? Sorry. alternative metabolic pathway. They just, you know that, you know details of lipoprotein metabolism, right? What is the lipoprotein complex? You know these VLDL, HDL, LDL, so many things you learned in your biochemistry classes. They are the one which actually transport fat from the cell to outside, right? Now, this lipoprotein complex has lipid, that is phospholipid, as well as protein component. And what do you call the protein which is also part of lipoprotein molecule? What is it called?
Apoprotein?
Apoprotein, yes. So this apoprotein, it's not even protein, but it is a part of lipoprotein complex, so you call it apoprotein. Now, when there is decreased protein synthesis in the cell, there is decreased synthesis of all proteins, both structural and enzymatic proteins, including apoproteins.
Oh.
You got it? When apoproteins are not synthesized, your lipoprotein complex is not formed because it's lacking apoprotein. When lipoproteins are not formed, there is no way that the lipid gets out of the cell. So the lipid gets accumulated within the cell. Very, very important. Please remember this concept. Very high. You want me to explain again or you got it?
Got it.
You got it. Okay, good. So that's how lipid accumulates within the cell when there is hypoxia for longer duration. Okay, hypoxia for few hours, it can show hydropic change or water accumulation because of arrest of sodium potassium pump. But hypoxia for several days, it will show fatty change. Okay. Also, this calcium ATPase pump gets impaired because this pump also requires ATP. And when calcium ATPase pump is failing, there is accumulation of calcium in the cytoplasm. Now, this is a reversible type of injury. At this time, if you restore oxygen supply, okay, suppose your patient suffered from angina, and suddenly you give sublingual nitrates, and it relieves the spasm, and the blood vessels gets dilated, and there is reperfusion of the myocardial cells, so there is fresh oxygen getting into myocardial cells. What happens? These changes reverse back. That's why it's reversible injury. Okay? And the person becomes alright, both symptomatically. And the cells also come back to its normal state. So there was a transient anaerobic glycolysis, transient swelling of the cell, all these things, but it becomes reversible. Except for cytosolic calcium. Okay? And if the ischemia persists, if it's long-standing, it becomes irreversible. Once it becomes irreversible, eventually it has to die. Okay? When do you call it irreversible cell injury? If there is persistent or severe injury, let us say hypoxia, it can take the cell to point of no return. That means the damage is so severe that even if you restore the oxygen supply, even if you reperfuse the tissue, the cell cannot survive. Eventually it will die. Okay? That means at a certain point, the cell will, the damage caused to the cell becomes irreversible. Now, scientists discovered that whenever there is damage to mitochondrial membrane as well as plasma membrane, the cell goes to irreversible phase. From reversible phase, it goes to irreversible phase. These are the two important structures, very high yield fat, please remember. Whenever there is damage to mitochondrial membrane or the plasma membrane, or whenever there is some problem with the mitochondrial function, then the reversible injury becomes irreversible. I mean, there are two causes. One is mitochondrial injury as well as plasma membrane. If it gets injured and if the integrity of the cell membrane is lost, then the cell suffers from irreversible damage. At this point, even if you remove the injurious agent, the cell cannot come back to its normal state. It will eventually die. Okay? That's what it says. And calcium plays a major role in irreversible injury. Okay? Please remember this. Now let's discuss the mechanism behind irreversible cell injury. So far we discussed mechanisms behind reversible injury. Now let's discuss about mechanisms of irreversible cell injury. One is mitochondrial damage. Okay? When can mitochondria get damaged? Whenever there is increased calcium levels, calcium ions in the cytoplasm, or oxidative stress, what is called free radicals. Okay? Actually, when mitochondria gets injured or when mitochondria is under stress, it will release free radicals, and the same free radicals can injure the cytoplasm. So it's a vicious cycle. So now you tell me what are free radicals. We discussed free radicals in next class. You must know this. What do you mean by free radical? Excellent. So it's a molecule which has got a single unpaired electron in its outermost orbit. And this single unpaired electron that is present in the outermost orbit is unstable, and it can oxidize another molecule which comes near this free radical. That's why it's called free radical. It has got one single unpaired electron. Okay, and free radicals are of many types. Certain chemicals can act as free radicals, and we have certain free radicals which are derived from oxygen, that is O2, and we call them as oxygen-derived free radicals. Okay, like we'll discuss about free radicals later on. And why should free radicals be released whenever mitochondria is injured? Do some guesswork. What happens when there is hypoxia? Mitochondria is stressed out. This decreased oxygen basically. Okay, and your mitochondria, basically your cells are getting suffering from ischemic damage. Okay, that means there is decreased oxygen supply and everything is disturbed. All metabolism is disturbed in your cell, and at this point, I think we'll discuss that later on. I don't want to confuse you. I wanted to give you an information about ischemia reperfusion injury, but I think it's too early for you to discuss that at this point of time. We'll discuss it later on. Okay. So these free radicals can injure mitochondria, and mitochondrial damage result in formation of high conductance channels, like what you call mitochondrial permeability transition channels, and there is release of cytochrome C into cytosol, which triggers apoptosis. Okay. What is apoptosis? Programmed cell. Excellent. So you know that. So that means a cell suffers from irreversible cell injury or irreversible injury whenever there is disruption of mitochondrial integrity. So when mitochondria is damaged, cytochrome C comes out, and that leads to apoptosis. That is one mechanism. The second mechanism is, okay, that's represented in picture here. You can see the mitochondria will show some transition, what you call mitochondrial permeability transition, because of which protons also escape. And when protons escape, there is no more ATP synthesis again. And there is escape of cytochrome C into cytoplasm. And the cytochrome C, when it comes to cytoplasm, it will trigger apoptosis or apoptosis. That is one mechanism of irreversible cell injury. The second mechanism for irreversible cell injury is damage to plasma membrane. So any cause which leads to damage to plasma membrane leads to irreversible damage, because we cannot fix the problem, fix the damage. Because what happens here is, let us figure out what all can cause damage to plasma membrane. Actually, they're all interlinked. Mitochondrial dysfunction can lead to plasma membrane damage. How? When mitochondria is showing dysfunction, there is no ATP synthesis. When there is no ATP synthesis, no phospholipid synthesis, because phospholipids require ATP to get synthesized. And when there is no phospholipid, the cell membrane loses its integrity, because the cell membrane is made up of bilayered phospholipids. Okay. Now, if these phospholipids are not produced, plasma membrane is lost. And whenever there is increased amount of calcium ions in the cytoplasm, they activate certain enzymes. These calcium ions activate certain enzymes like phospholipases. And these phospholipases can dissolve or digest phospholipid membrane, and the cell membrane gets damaged. Or lipid breakdown products, when lipases are activated, lipids are broken down and they can damage the membrane. Or free radicals can also damage. Okay? This is the best picture I think we can easily understand this mechanism of irreversible injury. Decreased oxygen, decreased ATP, decreased phospholipid synthesis, phospholipid loss, or increased cytosolic calcium, activation of phospholipase or protease leads to increased phospholipid degradation, and lipid breakdown products can in turn cause membrane damage. Or proteases can damage the cytoskeleton because there are structural proteins can lead to irreversible injury. I think it's the same repetition. When mitochondrial membrane is damaged, apoptosis gets triggered. And when plasma membrane is damaged, what happens? The integrity is lost, the integrity of the cell membrane is lost, and everything escapes. All electrolytes, fluids, everything are lost, and some of them get in. So there is loss of this integrity, a loss of proteins, enzymes, and RNA. And when the lysosomal membrane is broken, what happens? Lysosomal enzymes are released into the cell, and these enzymes can bring about autodigestion. Okay, and then, these are the enzymes that are present in lysosomes: RNases, DNases, proteases, phosphatases, etc. They all start digesting the cell, and the cell will have to eventually die. Yes, please?
Yeah, but don't lysosomal enzymes only function at acidic pHs?
I'm sorry.
Don't lysosomal enzymes only function at acidic pHs? So when they come out, they won't be active?
Repeat. You're talking about phagolysosomes?
No.
Because
Lysosomes, right? Their enzymes are active under acidic pHs, right?
I'll have to check it out. And your lysosomal, and you are telling that lysosomal enzymes are active only in acidic pH and not in
Yeah,
base.
because remember it has the proton pump and it
But-
always needs to
But the
pump.
content
That's the
also gets
contents.
released. The content, when it's released, the enzyme is out. So
Yeah.
is the content, which is low pH, right, which is acidic, and that's why it causes injury. It won't cause
But
injury.
please remember, when the pH goes very much low, when it becomes highly acidic, for example, when hypoxia is long standing, there is building up of lactic acid. When it becomes too high, it denatures the proteins. It can in turn inactivate these enzymes. We will discuss this much more in detail when we discuss coagulative type of necrosis. When these enzymes undergo coagulation, acid is a coagulant. So it coagulates these enzymes, lysosomal enzymes, and they become inactive again. Okay. So there is, maybe you're telling that they are active only in a particular range of pH. And at this point, the pH is not so less. So that when it becomes too less, again the lysosomal enzymes become inactive. Maybe they are still in that particular range, and because of which these enzymes are still active and they can bring about digestion of cells. Did I answer your question?
Yeah.
And eventually the cell dies by necrosis. Okay. Now something about calcium. I'll just take 5 more minutes because we are running short of time. I have to check your time. I think this is a repetition. When the cytosolic calcium increases, it activates various enzymes like ATPases, phospholipases, proteases, and endonucleases, and it will in turn cause digestion of these proteins. And now, where does this calcium come from? Either from out of the cell, it diffuses into the cell, or from the mitochondria, it enters the cytoplasm, or from the endoplasmic reticulum, it enters the cytoplasm. Okay? And once it increases, all these enzymes get activated, and they bring about digestion of the cells. Now, where exactly the reversible injury becomes irreversible? We discussed this before, right? This picture was already discussed. So I'm not going to discuss it for a second time. You got this? When we spoke about reversible injury, we discussed how ischemia causes, decreased ATP causes, swelling of cells, and decreased pH, and decreased protein synthesis. Okay? Once there is membrane damage, the cell suffers from irreversible injury. Okay? Once it becomes irreversible, there is influx of calcium, and cytoplasmic enzyme gets leaked out. That is why, that's the reason for your answer, why cardiac enzymes are elevated in myocardial infarction and not angina pectoris. This is a very, very high fact for you. Please remember, your enzyme levels in the blood of your patient increases only when there is irreversible injury and not when there is reversible injury. That is because the cell membrane is, loses its integrity and the cytoplasmic enzymes gets leaked out of the cell, and that's how they reach the bloodstream. And that's how you pick up in the lab test, when you do lab test, when you take a blood sample and pick subject for laboratory examination. Okay? So if you find CKMB and LDH in a patient who suffered from chest pain, that means these enzymes are increased in the blood. That means it has been leaked out of the cardiac muscle cells. That means there is loss of integrity of the cell membrane of these myocytes, cardiomyocytes. That means it's an irreversible injury. That means it is myocardial infarction. It cannot be angina pectoris. You got this point? Very, very high. Okay. So when you find elevated enzyme levels in any diseases, that means it is irreversible injury. Okay, it's not reversible injury. Now, little bit more about free radicals, then I'll conclude today's class. We already discussed what these free radicals are, and they have a single unpaired electron in the outermost orbit, and they can pass this electron to the neighboring molecule, and they can cause damage. And free radicals are generated by various mechanisms. For example, if we get exposed to ionizing radiation, what happens? This ionizing radiation splits water into hydroxyl radical and proton, or H free radicals. And both of them have unpaired electron in the outer orbit, and they act as free radicals. And these free radicals in turn can damage DNA, and the person can develop some cancer because of damage to DNA. Okay, that's how when a person gets exposed to ionizing radiation for a long time, he develops cancer, some leukemia, skin cancer, and all those things. Okay, certain chemicals can become free radicals. So carbon tetrachloride was once used in laundry industry, but I don't think they use it now. And accidentally, this carbon tetrachloride enters our body. It enters the bloodstream, goes to liver, and in the liver it gets converted into carbon trichloride. Carbon tetrachloride becomes carbon trichloride, and carbon trichloride is a free radical which can injure hepatocyte. Okay. Coming to oxygen-derived free radicals. Some free radicals are derived from oxygen. And you call them oxygen-derived free radicals. The best examples are superoxide, that is oxygen with one unpaired electron, and hydroxyl ions and hydrogen peroxides. Okay, we will discuss a lot about these free radicals, oxygen-derived free radicals in later classes. I think maybe tomorrow and also day after. Okay, and there are certain transition metals. What do you mean by transition metals? Like iron and copper.
They have multiple oxidation states.
Yes. So they are like cupric and cuprous, ferrous and ferric. So in ferrous you have 2 plus, or I mean the charge of the molecule is 2 plus, whereas when it is ferric it becomes 3 plus. Similarly, when it is cupric it is 3 plus and cuprous is 2 plus. So these molecules can activate conversion of one free radical to another. Okay, the hydrogen peroxide can be converted into hydroxyl radical whenever there is availability of cuprous ions or ferrous ions, and this is called Fenton reaction. Okay, so what is this Fenton reaction is about? Whenever there is a reduced molecule or metal like ferrous, it becomes ferric. in presence of hydrogen peroxide. Hydrogen peroxide itself is a free radical, but it becomes much more stronger free radical, like hydroxyl ions, OH minus and OH dot, and it becomes ferric. Similarly, cuprous becomes cupric, and it will convert hydrogen peroxide to hydroxyl ions. Okay, and this is called Fenton reactions. I think let's conclude today's class. And tomorrow we discuss how does free radicals bring about injury or damage. Okay? And if you have any questions, I'm available out of the classroom for a few minutes. You can come and ask me or clarify your doubts. Thank you very much.
Thank you.
Have a good day.
Thank you.
I think tomorrow we have more.
Yeah. I wasn't talking about you.
Still.